Hey, well, welcome. This is our first day review of late-breaking clinical trials. I'm David Cox, past SCAI president in 2018 to 19 and co-chair of our Communications Committee. I'm joined by our present president and good friend, Cindy Grines, who will be leading some of the discussions. And we have Luai Tabaza, Matthew Belford, and Drew Klein, who are going to go over some presentations and hit the high points. So we're going to start off with Drew. Can you go over and give us an update on the North American COVID-19 SCAI Registry?
Great, thanks, Dr. Cox. It's a pleasure to be here. I'm Drew Klein, one of the interventional cardiologists at Piedmont, Atlanta, and a pleasure going through NACMI Registry here just briefly. This was presented today by Pam Dagani, part of the Prairie Vascular Research Institute and University, Associate Professor at the University of Saskatchewan. Essentially, this is looking at all patients who presented with STEMI who are COVID-19 positive or a person of, under investigation that's presenting with STEMI or new left bundle, those greater than the age of 18, and then some clinical correlate of myocardial ischemia, either abdominal pain, chest pain, dyspnea, cardiac arrest, or on event. No exclusion criteria. And so the idea here is try to figure out what we're doing with these patients when the pandemic started. Here was the symptoms on presentation. Again, a lot of patients presenting with dyspnea in the COVID positive arena, chest pain, as well as some with syncope, and then out of hospital arrest as well. If you look at that, it's not insignificant. And also a number of patients presenting with in-house presentation of ST segment elevation of MI, which is always interesting because these patients have been shown in large studies to have delays to recognition and intervention. As not surprising, many patients had infiltrates on their chest x-rays, more in the COVID positive versus PUI. I think most interesting about this was the non-Caucasians, or those patients of non-Caucasian ethnicity had much greater ST segment elevation MI, especially in the COVID positive versus the PUI. They are also more apt to be diabetic. Patients that were in this registry as well as have an EF about the same, about 45%. If you look at the outcomes, patients that primary endpoint again being mortality, shock, those patients who had COVID positive did much worse, not surprisingly, versus age and sex max controlled. They had longer ICU stays, longer total length of stays, increased mortality across the spectrum as well. So these patients did quite poorly, and I think for all of us that handle these patients, I think this fits with what we saw clinically. COVID positive with a STEMI equals bad. Reperfusion strategies are interesting. I think many of us were discussing, should we just give these patients lytic and limit exposure to staph? However, thrombolytic use is actually really uncommon in NACMI, only less than 3% of those in COVID positive. Primary PCI was the predominant reperfusion modality. Medical therapy was actually more common in COVID positive. I think that's consistent with those centers that decided to try to limit exposure to their staff. And that was upwards of 23% of just medical therapy for STEMI or new left bundle. Interestingly enough, when you looked at culprit versus non-culprit distribution, almost 20% had no culprit vessel on angiography. I think many of us saw these quote-unquote COVID EKGs that look like ST elevation. You took these patients' lab and they don't really have anything, or we can't really identify what's going on. So there's definitely some issues with presentation. Left main circ, everything else was, you can see, about the same as RCA, or multiple culprits were also there, so diffuse thrombosis. But I think it's interesting that 20% had no culprit vessel on angiography. If you look at the predictors of death in COVID plus STEMI, being intubated is bad. Obviously, it consisted with more pulmonary involvement as well from COVID. If you were in shock, if you were also in-house, and then again, that's consistent with what we've seen in other studies outside of COVID, that if you get an in-house STEMI, that's worse than being just across the street. Diabetes, again, older age also. If you got a PCI, it actually decreased your predictor of death. So overall, the interesting thing is that the take home from NACMI was if you had COVID positive patients presenting with STEMI were more likely to be diabetic, I think most of us saw that, belong to an ethnic minority, very high, 30% in-hospital mortality. Predictors included age, shock, and diabetes, and primary PCI remain common and associated with reduced mortality. I think we know that across the board prior to the pandemic, but I think we've borne out here in the NACMI registry that the way to go is primary PCI to reduces mortality. And a high proportion with no corporate vessel at all, which is, I think, interesting and consistent with either what we're seeing with these weird EKGs and or multi-vessel issues going on. And this registry is still recruiting. So ongoing, I think, as we're now starting to see another wave of COVID hit the hospitals, this is still recruiting. So if you're one of those hospitals, please involve the NACMI registry. Thank you very much.
Drew, that was
actually,
great.
if you're not involved, please get involved.
Or get involved, yes.
Yeah, it's a very important study.
So Cindy, Drew, I'm still confused. You know, this is now published and I've read it and read it and read it. And I'm still confused. What does the NACMI registry teach us about how to manage these patients? You've got a COVID positive, you got a PUI that looks like COVID. Do you get an echo and only go to the lab on those people that have a wall motion abnormality, or do you just treat them as if any other patient and ignore the fact that they're COVID positive? What's your thoughts? Drew, you first and then Cindy.
I think my take on it is if it's a clear-cut, classic ECG, not one of these weird, funky, we don't know what it is, 2-3 AVF, V1 through V3, classic LED, classic CIRC, classic right, you take them to the lab. And I think that's the way to go. It reduces mortality. If it's one of these weird EKGs that we can't really decipher what's going on, I favor going right to an echo stat and doing a fast, bedside echo. And then if you got a wall motion, going right to the lab from there. Now with echo being available in your ER, I think you can do that right away and then determine where you're going to go.
Cindy, what's your thought?
Our SCAI statement on STEMI management during COVID, precisely. That's exactly what our guidelines recommended that we do. And keep in mind, David, then when this all evolved, there were actually a few articles and recommendations to go back 20 years and start giving these patients thrombolytic therapy, and there was no data, no evidence whatsoever for that. And there was a lot of concern because many of these patients might have a patent vessel. It might be localized pericarditis or myocarditis. And so you're going to get all the harm from thrombolytic therapy without any of the benefit. And also at the time, the only data available was coming from New York, and they said that there was an 80% mortality in those patients who went to the cath lab. So obviously, why would you take them to the lab if in those circumstances? So we wanted to get a different perspective and to try to get a large number of patients. I'm glad to see that we got over 300 patients with COVID positive. So now we can make these kind of determinations. And most of them have an infarct related vessel, 80%. Wow. And most of them were treated with primary PCI.
Yeah, I think we just need more and more enrolled patients, though. I think the power of this is very interesting to sort of see COVID phase 1 and COVID phase 2. And I will give SCAI credit because Cindy was involved in sort of the discussion about the paper. Do we include lytic therapy as an option? And it's interesting to me that we finally decided to include it as a possible option, but most of us said, we're not going to do it. We're not going to give lytic therapy. So I think we sort of read the paper and said, no, we're going to stick with the tried and true. I'm very proud of that.
Right, and that's reflective of what happened across the country. Very few patients were treated with thrombolytic therapy, which is gratifying to see.
Absolutely, absolutely. Okay, we're going to move forward. We're going to let Matt Belford go through 2 presentations. Let's put up Matt's first slides. There we go. And the first thing that Matt's going to review is an interesting paper from Jacob Genser looking at the classification of mortality risk with the new SCAI shot classification updates.
Great. Thanks, Dr. Cox. Thanks, Dr. Grines. Excellent presentation there, Dr. Klein. I say we talk about the new SCAI shot classifications. Obviously, it was fun to be in the room 2 years ago when that was presented in 2019. But basically what they set out to do was really define mortality risk and see if these stages actually tied to mortality risk through basically a systemic review. They went through and actually identified 15 different studies, which encompassed about 15,000 patients, with a combination of things. They basically were some cardiac arrest, some cardiogenic shock, and then just some patients in the cardiac care unit. And they went through and classified them on the SCAI shock algorithm here. Obviously, just as a refresher, that's obviously the A through E classification for stages of shock, and really helped to try and define where the patients were with regard to mortality as their primary outcome. Most of these studies were large retrospective studies. One was a prospective study. Most of the patients were encompassed in single center, like I said, retrospective places. Interestingly, the different phenotypes was a little bit hard in the sense of the population there, and that they laid that out very nicely with regard to whether they were all CCU patients, cardiogenic shock, AMI, or obviously out of hospital arrest. They then went through on the next slide and really laid out how they defined them into those SCAI shock stages. Some of those were driven by physician assignment. Some were sort of, through these different categories of formal diagnosis of shock. Obviously, exam was hard to do and hard to define in the literature, but vital signs, pressors, mechanical support, basically CPR, lactate, renal function were sort of their classification things. With regard to the results, there was basically a very clear, so there was wide range of the presentation of shock within these different groups, which is not surprising based on CCU shock or out of hospital arrest in terms of where they laid out. But what was compelling about it is that when you look at outcomes with regard to mortality, there was this clear, consistent, stepwise progression, which sort of fits with our intuitive base. If you flip to the next slide, they lay out basically that there was a nice stepwise thing for shock. Class A had a 1 to 5% mortality. B was in a wide range, 0 to 34% mortality. C 11 to 54%. D 24 to 68%, and E 42 to 77% mortality. They noted clear correlation with a few other things as well, in addition to sort of where the patients come from, but cardiac arrest, inflammatory response, which they included, basically SIRS criteria, worsening hemodynamic parameters. They had some echo variables that they looked at. And then most notably, I think, and most compelling, were basically age and then basically progressing through increasing shock categories. So basically, if they went from, a class C up to an E, those folks did notably worse. So there were pretty clear relationships with those things. Basically, this study very much, I think, in my mind, validates the SCAI shock paradigm in very real world populations. And I think it fits with the intent of that 2019 consensus statement, which was to make sure that we're all talking about consistent patients with regard to diagnosis and treatment, and that a SCAI shock classification A patient is very different than an E population. It really gives us a nice, useful point estimate of mortality within these groups, and tied to these classifications. And I think it validates that we're all kind of talking about the same thing within these things. And then really what their intent going forward is to help use this to adjust the classification system. And that's certainly in the intent of their study here.
Great, Matt. William Faulkner said the past is never dead. It's not even past. Do you find these types of analysis helpful as opposed to going forward with some of our new randomized trials? I mean, we got danger shock, we got a couple other shock trials that are going to be very exciting. I was very impressed with Jacob's Mayo Clinic analysis, but that's the Mayo Clinic. That seems more powerful to me than sort of a PubMed analysis. What are your thoughts about that?
I think it's interesting, David. I think both of those things are helpful. I mean, I think the power of this is 15,000 patients, and the fact that I think there were clear, consistent ranges across the populations. Certainly an RCT, if this was, 7 RCTs, I think we'd all be a lot more interested. And certainly going forward, I think having an a priori classification of what stage of shock that patient's in, would be really helpful and really insightful. But I think for the evidence we have at the moment, it's helpful that it really validates, to some degree, our preconceptions here. Certainly I think we would have a very different conversation if the mortality in class C, D, and E was all the same number. It would put some real question in my mind about the validity of our paradigm here.
Cindy, you and I have talked about balloon pumps a lot. Does the SCAI classification suggest that there's some class that balloon pumps may in fact help, or is that just an unanswered question right now?
Well, I don't think that they could tell that, David. And a part of the problem is that this the SCAI shock classification is being applied to a variety of different situations. So some of those studies were just everybody who came into the intensive care unit. Some of those studies were all STEMIs with cardiogenic shock. And some of those studies, the majority of the patients did not have ischemic heart disease. They had chronic congestive heart failure that just tipped over and they ended up in the ICU. And so that's why you're seeing a wide range in terms of, the prognosis. But I think it's clear that the prognosis does vary based on the SCAI shock classification. I think that there are a lot of things that came up. We need to tighten up a little bit the cardiac arrest, because if you have a cardiac arrest doing a STEMI, David, and the patient gets 2 chest compressions, right. I mean, you really think that that's going to harm the patient? And every single trial done on, or not trial, but, observational study on whether you have a ventricular arrhythmia, if it's within the first 24 hours, it's meaningless from a prognosis standpoint, right? Well, it's very different than somebody who presents with PEA, or somebody who's got cardiac arrest due to either PEA or asystole, right? So we're going to try to tighten that up if possible, and maybe come up with some guidelines in terms of, prolonged CPR. I think that would be a prolonged CPR, or, if you look at the shock, culprit shock trial, it was all about anoxic encephalopathy. That was what was killing patients. It wasn't necessarily they were dying of congestive heart failure. So I think, some of these studies are really helpful. It absolutely validates it, but I think that we can probably do a better job at discriminating between the duration of cardiac arrest and the etiology of the shock.
Great. Yeah, I think culprit shock is a great lesson to us all about how out-of-hospital cardiac arrest really affects what these numbers are. And I think I'm so proud of what not me, but all of you that have worked on this. I think it's one of the most important accomplishments that SCAI has ever done. All right, Matt, you did such a great job with that one. I think I'm going to let you do another one, okay?
Thank you, David.
All right, you're going to give us the review or your thoughts about the final results from the National Cardiogenic Shock Initiative. We're going to be presented by Barbara Basir and Bill O'Neill. Matthew?
Thanks. This was a great talk earlier today, listening to Dr. Basir talk about sort of the summary of the NCSI. Obviously, those who were there got to see basically it's a prospective, non-randomized, single-arm, multi-center study. They screened about 1,103 patients at 80 centers, which was a pretty good mix of actually academic and community centers. Calling the community centers, though, doesn't do justice. I think a lot of these places were very facile with cardiogenic shock and comfortable with sort of, a wide range of mechanical support. Interestingly, of those 1,100 patients, they actually enrolled about 406. They got to exclude about 697. Some of those were both exclusion criteria, but also some of those were a failure of inclusion criteria. And I think that's where it gets interesting in terms of looking at the outcomes here. About 231 of those didn't have a PCI, and that was certainly the largest of the inclusion miss. And then of the largest exclusion criteria, obviously a chunk, about 195 of those patients got a prior balloon pump. And then alluding to what we were talking about earlier, about 108 of those had out-of-hospital arrest for greater than 30 minutes. And that's a challenge in the sense that, we screened a lot of patients to get down to the 406 patients, but we're really trying to look at just one very focal thing here. With regard to the population, it was very representative, I think, what a lot of us see. The average age was about 64, 24% female, and about 40% diabetic. A quarter of those patients actually had prior heart failure. Many had prior coronary disease, including MI, PCI, and CABG. What's compelling with regard to the outcomes is the survival metric. So if you look at basically the procedural survival of 99% overall, that's over all populations of a very sick cohort, that's impressive. And then you look at sort of the discharge survival of 71%. And then if you scan down to that 77% 30-day survival for all C and D shock patients is actually one of the highest survival point estimates noted, again, comparing against historical controls. And I think that's one of the big challenges, is that we're doing this relative to, multiple prior shock trials. This was, like we said, a sick cohort, though. If you look at sort of the overall review, again, 25% of these patients were in E group, and over a third of these folks had CPR a priori. You can see there, relative to culprit shock, IABP shock, the average lactate was 4.8. And the percent of patients that had a lactate greater than 2 was 77%. So this was certainly a sick population, consistent with some of our other trials. So I think that puts in light where their numbers are with regard to the survival, and particularly in both the acute and then also the 30-day numbers. It does an interesting piece both to the mechanical support, but also to the algorithm. And I think that's an important piece of this. It's important to note their conclusions that this was the largest North American, AMI cardiogenic shock trial in the last 20 years, with impressive improvements relative to these historical trials. And they lay this out here with regard to culprit, revascularization, prior medical therapy, IABP shock, and then obviously current day with NCSI. I think this is a really important data point for us, both as a future driver for a true randomized trial for mechanical support with Impella, and then also just kind of hints potentially at an interesting algorithm change for all of us with regard to cardiogenic shock. I think this is going to drive maybe a perspective change from pure door to balloon time to maybe door to support time, and giving us some interesting hints at where we can go with this. The algorithm itself was interesting, and I think is going to impact a lot of cath labs. I think escalation is going to be an interesting thing to look at in a randomized trial, and certainly going to be something that we're looking at out of the data from this. I think it's going to be really interesting to see sort of how people progress through the different types of mechanical support. And I think the same thing that we've all talked about, really what we're excited about is a randomized trial, and that's certainly planned. They talk about that in their last line there, that Recover 4 is basically going to give us a randomized trial of Impella for this.
So Matt, that's just fantastic. Help me out here. Think Impella does a great job. I think Impella in most labs is easier, as easy to put in than intra-aortic balloon pump. But the reality is we still place more balloon pumps than we do Impella. And of course, if you got a balloon pump first and then an Impella, you were excluded from this registry. So how is Recover 4 going to help us answer this question? Because I think balloon pumps are going to be excluded, right?
No, balloon pump's going to be in the other arm. So it's basically going to be, Impella versus balloon pump. And I think that's going to help really clarify out where it fits in this. Like you said, I think that's part of the challenge of this data, is that if you get a balloon pump first, it's not looked at here. And I think the concern is, what's the acute benefit? And it's hard to answer that question if you get both. So an RCT will give us a much cleaner answer.
Absolutely. Cindy, so all these patients then in the Recover are going to be SCAI Class D, is that right?
No, I think that it's cardiogenic shock, the classic cardiogenic shock. So basically that would fall into C.
Gotcha.
You have to have a low blood pressure, hypoperfusion, and some level of treatment that they didn't initially respond to, or vasopressor.
Gotcha. Drew, you guys are doing a lot of shock at Piedmont. I'm just curious, do you see yourself participating in Recover 4 aggressively, or do you think the question has kind of already been answered?
I think it's actually an ongoing question. I think, I think we would definitely be open to participate in it. I think I agree with you. You can put in a balloon pump just as fast. You can put in Impella. I don't think that's going to be an issue. I think there's always this, door to balloon time. I think most of us are doing door to balloon time, so we got plenty of time to be able to put in an Impella beforehand. I do think, PAPI scores and understanding kind of where your patient is going to be important. I also believe that this is going to kind of stem from the golden hour of trauma, and the faster we can get to our patients, and depending upon when they present, I think that will make a difference. If patients are presenting late, I think we're going to have a challenge rescuing them. If they're getting quickly, we get that first hour, first couple hours of when they're starting to deteriorate. I think that's where we can really make a difference. So I'd be curious to see where that pans out as well.
Yeah, I think Cindy's message about COVID, right? We got to get these patients out of the house to the emergency room and not sit around. And Cindy made that very, very clear. All right.
Problem though is cardiogenic shock again is so heterogeneous, and you can have somebody like Drew's describing with somebody in that golden hour. You could have somebody that's been languishing for 48 hours, and obviously the longer the shock has been present, the worse the prognosis. And then the other thing is they did exclude patients who had cardiac arrest with anoxic encephalopathy, and I think that probably helped boost the survival rates. And I think that's totally appropriate, but you can't really compare this trial's outcomes to culprit shock, which included those patients with.
Right, exactly. That's an excellent point. I mean, this isn't culprit shock. So I'm glad to see the numbers that they got, but I think you got to make sure you understand what population they're actually treating. I mean, it's an excellent point. Okay. Luai Tabaza from Virtual Health near Philadelphia, New Jersey, is going to do our final presentation. It's a little dense, and we gave him this assignment because we knew he would do a great job. And he's going to talk about a Chinese study that was presented this morning. I had the privilege of doing the press conference on it, optimal duration of DAPT after PCI. Luai?
Thanks, David, and nice presentations by Drew and Matt. This presentation was by Dr. Wang on behalf of the registry, and basically it looked at a real-life population and the duration of DAPT of less than 12 months and more than 12 months in a particularly important population, which is what they defined as TWILIGHT-like ACS patients, which were defined as high-risk features in both clinical and angiographic criteria. So they looked at patients who are older, who are females, who present with ACS and positive troponins, had PAD, diabetes, and reduced GFR. The angiographic criteria included multivessel disease, longer lesions, thrombotic lesions, bifurcation lesions, left main and prox LAD, and calcified lesions requiring atherectomy. And the study design is interesting that it was physician-driven, and they took only ACS patients, as I said, and they looked at specifically those with high twilight-like risk profiles, and they only started with those who had no events for 12 months. So they received 12 months of DAPT, no events, and then they separated them to those who continued DAPT and those who stopped. And this reflects a lot of what we see in our practices, the baseline features in the study. You can see that more patients received longer-term DAPT that had diabetes, that had prox LAD, that had in-stent restenosis, high calcification, and those who received second-generation drug-eluting stents. So it kind of reflects more of the real-world practice that we see across the board. They did multiple different analyses. All of the analyses, as you can see, shifted in favor of longer DAPT, and in all categories, including death, MI, and bleeding risk. As far as they tried to separate the data into how many criteria on the high risk features it met, and all different categories showed still a benefit to prolonged DAPT compared to the less than 12 months of DAPT arm. And this the overall analysis for all the different number of criteria that were met still favored the prolonged DAPT, including, again, death and myocardial infarction and less risk of bleeding, or similar to less risk of bleeding despite the prolonged DAPT. So the authors concluded that in this particular study and with patients with TWILIGHT-like risk profiles presenting with ACS, there was benefit to continuing DAPT beyond 12 months compared to less than 12 months in terms of major cardiovascular composite endpoints and while maintaining low bleeding risks. Now, going back to where this stems from, TWILIGHT study looked at, just to summarize, looked at patients who received monotherapy with ticagrelor after 3 months of DAPT, and particularly those with high risk features. And what TWILIGHT showed is that patients had similar overall all-cause mortality and less risk of bleeding events. While this data does not carry the same weight, obviously, the TWILIGHT was a randomized clinical trial where this is a registry, a prospective registry. This shows a different kind of a set of results here and favors longer term DAPT. So it raises the question again, maybe do we need more data before we shift to shorter term DAPT as our stent technology and pharmacology improve?
Louis, I think you really nailed it. That is the question for me that I just struggle with, because after TWILIGHT, I was all excited, right? Okay, yippee-yi-yay, we can get away from DAPT. And then this registry comes and some of the DAPT registry data. Are you surprised that they didn't use any bleeding score, DAPT bleeding, precise DAPT? They really just didn't look at any scores of bleeding to try and sort out who should get longer.
That's
DAPT.
right. Yeah, and I think there's a few questions about, and we were discussing this, a few questions about what type of DAPT was offered, what was exactly done. And this might be, we'll have to wait until we get more information and the nitty-gritty of things. But I agree with you. I think we need more information about what was the practice used during the study. Was it unified? Was it very variable? And how applicable it would be to our daily practice.
Yeah, I think Dr. Wang mentioned most of these patients were on Plavix, but I don't remember the actual number. Cindy, we're all clinical trialists. We all believe that science worships at that altar. How do you tell those of us out in practice to interpret this study after TWILIGHT?
Well, first of all, I think that it's not completely surprising for a few reasons. There were prior to TWILIGHT, there were two other trials, SMART-DATE and the REDUCE trial. I think SMART-DATE enrolled 3,000 patients randomized, and REDUCE was 1,500 patients with ACS. And both of those trials showed a higher ischemic event rate by prematurely stopping the DAPT. Now, the difference with TWILIGHT, though, is they did, most studies that stopped DAPT, they stopped the P2Y12 inhibitor and just kept them on aspirin. TWILIGHT was the exact opposite. They stopped the aspirin. I think most of us feel very comfortable stopping the aspirin. So I think that's a very important distinction to make. Now, I absolutely believe randomized controlled trials bet more so than a registry. And this registry in particular, we don't have a lot of details about when the agents were stopped, whether they stopped Plavix or stopped the aspirin, the reason for stopping it. It's possible that they had bleeding and that's why they stopped the DAPT, right? I find it inconceivable that patients who were given prolonged DAPT actually had reduced bleeding compared to the ones who were DAPT, right? That doesn't even make sense. Wow. So I think this raises a lot of questions that we'll have to try to sort through when the manuscript is in press.
Sounds good. And I think that's why we look at published manuscripts, right? We look at presentations, we hope it's clear, but it's really the manuscript that's the foundation of our of our science. So listen, this has been a fun 45 minutes. I want to thank Luai Tabaza, Matt Belford, Drew Klein, most importantly, Kimberly Powell for getting us together, and really most importantly, Cindy Grines, who has just had a challenging year as SCAI president, but has met that challenge wonderfully. And I just only wish I could drive to Atlanta and give you a hug, because you've done such a great job and been quite the leader that we all knew that you were going to be this year. Thank you, Cindy.
Thank you so much, David.
All right, guys. Thanks a lot.
Everybody.
Thank you.
Thanks, everybody.
Thank you.
Jim?